So good afternoon, dear chairpersons, and I take this opportunity to thank Dr. Ragini Agarwal Madam and Team Akriti for this fantastic event that they have organized, and it is indeed my proud privilege, that I just got installed as the chairperson of the Breast Committee Foxy, and this is a fantastic event that Delhi has organized. Divya, you are indeed going to be a key person in our committee, and you are lived up to your name. Well, so Akriti is not like the India-Pakistan match where nobody performed initially. Each and every player, each and every speaker has spoken so fantastically. They've all, had their 4s and 6s. And now I don't have to be like the Virat Kohli where I have to have 2 6s in the last over. I can just do my bit. I can just, give my presentation and the match is already won. So, respected organizers, it has indeed been a pleasure to be here. I'm going to talk about imaging in the breast. So, let's start with a show of hands. How many of us know a family member, a friend, a relative or a neighbor who's had breast cancer? I think all of us, is it not? And that's exactly why we are here today, to find out that who's, there's the saying that by Pablo Picasso who said that who sees the human face correctly? The photographer, the mirror or the painter? Quite a difficult question, is it not? And so we also have this question, who sees the breast correctly? Ultrasound, mammography, MRI or somebody else? And so let us just go through all these various imaging modalities and see what exactly each one does and what exactly we need to know about them. So what are imaging modalities? It is a type of medical imaging technique which utilizes a certain physical mechanism to detect patient's internal signals which will reflect either anatomical structures or physiological events. They use different forms of energy and they help in the diagnosis, the treatment plan and response to treatment. Imaging of the breast, we have ultrasound, mammography, MRI, electrical impedance techniques and nuclear medicine techniques. What are the objectives of my talk today? To identify the various imaging modalities for screening of the breast and for diagnosis. So friends, we are talking about two different things. One is which imaging modality is a screening modality and which modality is going to be used for the diagnosis of a problem which we have in hand, essentially breast cancer. It helps in the early diagnosis of breast, what is going to help us in the early diagnosis of breast cancer? This is considered vital undoubtedly because statistics have shown a 5-year survival rate of 96% for those whose cancer was detected in the early stages, and we all know that the biggest problem in our country is the late diagnosis of breast cancer, stage 3 and stage 4. Probably the incidence may be less in our country as compared to the Western world, but the mortality is much more higher in India. This is exactly what we have to tackle. We need to have a consensus on which modality to be used and when, and decide on an imaging protocol which is best suited for our patient. So we come to the most loved imaging modality as far as the breast is concerned, which is mammography. Most common method of breast imaging used for screening as well as diagnostic purposes. It uses low dose amplitude X-rays. So friends, let us not worry too much about the radiation part. The benefits of a mammogram are considerably much more than the fear of the radiation part. Cancerous masses and calcium deposits are going to appear brighter in the mammogram. It is a good method for detecting ductal carcinoma in situ and calcifications. Currently, mammo is the gold standard method to detect early stage breast cancer before the lesions become clinically palpable. So, how much ever we feel that I am doing self breast examination, I am going to my doctor for a clinical breast examination, still friends, it is necessary to do a mammo because the mammo is going to detect lumps which are not palpable. And so, let us again have a show of hands as to how many of us gynecologists and other doctors have had a mammography in the recent past. Okay, quite a few, and we want to change the scenario and make sure that each and every gynecologist has definitely done a mammo so that she can counsel her patient and make sure that her patient also does it. So a mammography has helped to decrease the mortality rate by 25 to 30% in screened women when compared with the control group after 5 to 7 years. Randomized trials of mammographic screening have provided strong evidence that early diagnosis and treatment of breast cancer reduces breast cancer mortality. There are innumerable papers on the net telling us about the benefits of early diagnosis with mammography. This slide is thanks to Dr. Sneha Bhuyar Madam as to when the American Cancer Society guidelines of 2015 tell us about the screening protocols. Age 40 to 44 years, there is an option to begin annual screening. Age 45 to 54 years, annual screening is mandatory. And 55 years and older, every 2 yearly screening is okay. Option to screen annually is also there, and you discontinue screening when the life expectancy is less than 10 years. This is a little busy slide telling about the various types of mammographies. What we need to realize is that now we have very advanced mammography techniques available, which is the digital tomosynthesis mammography, also called as the 3D mammography. We all love 3D movies, we all love the 3D images that come up on the screen, and so do the radiologists, because the kind of view that they get of the breast, the kind of angles they get with the 3D mammography is fantastic, and so it is definitely preferred to do these kind of digital tomosynthesis mammographies. Of course, it depends upon varies from area to area, depends upon what your city has and what is affordable to the patient also, but this is what is in for today. In another variation called ductography, contrast agents are going to be used to determine the presence of a mass within the ducts. Now this is especially useful in the cases of abnormal nipple discharge when there is no palpable lump and you are suspecting probably a papilloma or an early DCIS, that is ductal carcinoma in situ. I don't know much about this latest technique. Maybe some of our colleagues here can tell us about the contrast enhanced digital mammography, which uses an intravenous injection of an iodinated contrast in conjunction with mammography, and they say that it is better for dense tissues. I think the biorids is something that each and every one of us has to know. We are not radiologists undoubtedly, but when you get the mammo in front of you, you at least need to be able to make head or tail of it, and that is very, very important. Okay. So when they say it's biorids 0, it means that there is additional imaging or prior examinations. You need to have additional imagings are needed. It doesn't mean it is negative. Biorids 1 means it is negative and a routine screening for that particular patient is just fine. Biorids 2 means it is a benign lesion. Look, suppose you have a fibroadenoma, okay, and you are a little worried about her, you send her for a mammo, or she's gone for a routine mammo and this find a small fibroadenoma, but they label it as biorids 2, saying that it is definitely benign. We are all relaxed in that particular condition. Now biorids 3 is probably benign. It could be a slightly elderly lady with a slightly largest lump, which even the radiologists feel is only probably benign. Then you're going to have a short interval follow-up of 6 months, not 1 year, and the possibility of cancer is more than 0%, but it is less than 2%. Then suspicious again has 4A, 4B, 4C, highly suggestive of malignancy and known proven biopsy proven malignancy. There is one more part in this biorids classification where they also classify the breast, whether it is fatty, whether there is only scattered fibroglandular densities, heterogeneously dense and extremely dense. Friends, you would be really worried about the extremely dense breasts, because those are the ones where even mammography can sometimes miss many lesions. So you can see a very, very tiny early CA breast in a very good mammography image. This is courtesy Star Imaging Center, Pune, and Dr. Aparna Atre has been very kind to share a few of her images with me. This is how fibrocystic disease looks on mammography. All of us would really worry about this also, but I am sure our radiologist friends, which we have over here, will be able to guide us more about this. We move ahead to ultrasound. All of us, most of us have an ultrasound machine in our clinic, friends. And so why do we restrict ourselves to only ultrasound of the uterus or of early pregnancy, or if you are a trained radiologist, even of your pregnant patients? Why don't we venture into the field of ultrasound for the breast? It is very simple. Anything is a learning process. Just as we all have learned to look at the uterus and the endometrium, we can also learn to look at the fibroadenomas. We can learn to look at the simple cysts and maybe even finish the aspirations of the cysts as well. That is exactly what I've been doing. Thanks to me being in the breast committee for the last 5 years, thanks to Sneha Bhuya's training, thanks to Kavita Bapat, but I feel reasonably accomplished in this particular field. It is an easily available, highly accurate tool with a good resolution probe is definitely required. It was previously used only to distinguish lumps from cysts. However, it has been found to be able to characterize masses. It improves the differential diagnosis of benign and malignant lesions. Local pre-op staging, detecting multicentricity, looking for lymph nodes, and guided biopsies and aspirations are possible under ultrasound guidance. It is the best imaging modality, friends, in the younger age group and for women with dense breast. Again, another important take-home message. One more very important feature is that the pregnant and lactating mothers, benefit a lot from this ultrasound, essentially because it does not release radiations, something which we just might be worried about. Continuous real-time images can be captured. It is an adjunct to mammography in the assessment of both palpable and impalpable breast abnormalities. But very important to remember, ultrasound screening in asymptomatic women can cause an unacceptable false positive and false negative outcome, friends, and therefore it is unacceptable for breast cancer screening. Again, a very important take-home message. The diagnostic yield of mammography with an automated whole breast ultrasound for women with dense breasts and or an elevated risk of breast cancer is said to be much better. Again, this is a field which I don't know much about, that there are now advances in ultrasound technology also, and you get better views of the breast along with sonoelastographies. Again, numerous papers on the net. This is the J-START trial with 72,000 women, and what do they say? That the mammography plus ultrasonography arm was one of the arm, and only mammography was the second arm, and they reported that the cancer detection rate was 3.3 per 1000 screens in the mammo arm as compared to 3.9 per 1000 screens in the mammo plus ultrasound. And so I'm sure each and every good diagnostic center always combines mammography with ultrasonography whenever they are suspecting malignancy. Again, very large studies where full field digital mammographies have found to be and ultrasound together are found to be the perfect screening method. Detectability of breast cancer by ultrasound is 96.5 or full digital mammography. So everywhere, the American College of Radiologists, everybody are claiming that mammography along with ultrasonography is the best. So actually this was a video which was running. This is a more transverse than vertical lump, and this is a young girl with a fibroadenoma, and so slowly and steadily you just start playing with the probes, just start looking for simple lesions, and you can also reach a conclusion. Obviously we are going to send them to the radiologist undoubtedly, but it's good to understand the breast. What are the benign characteristics on ultrasound? A well circumscribed lesion which is wider than deep, gentle curving smooth lobulations, some pseudocapsules, all these are indications of a benign lump in the breast. Ultrasound images of fibrocystic disease, you can see the cysts very clearly. So how are the simple cysts? They are circumscribed, round or oval, and echoic with posterior enhancement. We just said that they are BI-RADS 2 kind of cysts. Fibroadenomas. Now this can be a slight situation. So a newly palpable mass lesion, for it to be labeled as benign, all imaging criteria have to be met with. Anything other than this has to be biopsied, friends. The HP is to be obtained prior to excision. The rule is always do the imaging first, then do the biopsy, and then only decide which form of excision you wish to go ahead with. No additional imaging should obviate a biopsy. So you feel you're going to do an MR and then you don't have to do a biopsy? No. Whenever in doubt, always do a biopsy. Thermography is going to use, what is the basis of thermography? That cancerous and precancerous tissues have a higher metabolic rate, resulting in growth of new blood vessels, which causes a higher temperature over there. And it has been claimed that this thermography is going to be able to diagnose breast cancer at least 10 years in advance. We have Dr. Kabra somewhere. We just might ask him whether anybody really does thermography. I was using this at least 10 years back. But the biggest problem is that the analysis and interpretation is totally analyst dependent, and not many people have too much experience in thermography. So not much used as a screening modality or as a diagnostic modality. And of course, now coming to MRI. Please don't go on that image. I've just put a GIF to wake everybody up. But whenever you do an MRI of the breast, the patient is lying prone and the breasts are in a small cavity kind of a situation, so that they do not move much. Okay. So what are the advantages of an MRI? Very good resolution, allows the simultaneous evaluation of both the breasts. It is used as a screening test along with mammo in women having the BRCA mutation and those who are at a very high risk of breast cancer. So very important, you are going to use it as a screening test also, not only as a diagnostic test. But it is almost always combined with a mammography also. It helps to evaluate cases of inverted nipple, problem solving investigation in case of an equivocal mammogram, ultrasound or physical findings. It helps to decide if you need a lumpectomy or a mastectomy, whether you can save the breast. In axillary node malignancy with an unknown primary site, probably you would want to do an MRI. Staging of the disease, finding multicentric disease, all this is possible with an MRI. So what are the problem areas of an MRI? Not routinely performed, probably because of the high cost and limited availability. In cities like Delhi and Pune, where you have everything available, this may not be a situation, but in most tier 2 cities, it could be a problem. It does not show microcalcification, not good at diagnosing ductal carcinomas, may lead to false positives, can take up to 1 hour, may be used in benign breast diseases only in those who are at high risk for malignancy. These are a few more techniques which I found on the internet. So just for the sake of completing the list, Sinti mammography, which uses a radioisotope to visualize lesions, optical imaging which uses infrared wavelength light to detect lesions in the breast, electrical impedance tomography, and of course PET CT we have all heard about, especially when you want to look for distant metastasis. Nuclear medicine imaging, it's a nuclear medicine imaging technique, the PET. Malignant tumors are characterized by increased glucose metabolism compared with normal cells. We talked about increased temperature in thermography. Yeah, we talk about increased glucose metabolism as compared to normal cells, and this produces a good contrast between the cancerous cells and normal cells in the PET images, and this is exactly what is done in PET. It is expensive and yields poor resolution, and the patient is subjected to radiation exposure. Okay, so we have sort of come to the end of the talk. And before everybody goes home, let's give them a small test over here. And so, dear audience, I would really want you to participate in this. A young 35-year-old girl with breast implants. We just heard a fantastic talk on breast implants by Dr. Gupta. And is he here? Okay. And he has a history of, she has a history of, strong family history of breast cancer. What would be our screening technique? It is MRI. You can do a mammo also, because we just heard that even if the car tire goes over it, the implants are not going to break or dislodge. So mammography, MRI, depending on anything, but yes, MRI is usually better. A 45-year-old wishes routine breast screening, no family history, nothing. Fantastic, that's right. 52-year-old with abnormal bloody nipple discharge with no palpable lump. क्या करेंगे? Cytology of the discharge has no gross significance, so we will not talk much about cytology. Mammography and ultrasound, and SOS ductography. Yes, that is correct. A 55-year-old with a large fungating mass over the right breast. Okay, that's a good answer. I didn't thought of that. All right. So ideally mammography, but it can be very painful because it's a fungating mass, and so maybe you might have to subject her to an MRI and maybe a PET scan to look for metastasis. BRCA positive 30-year-old wishes breast screening suggestions. She's BRCA, she's 30. BRCA positive. MRI. I think we'll go for MRI, no? MRI, yeah. We'll go for an MRI. So thank you for that audience participation, and in conclusion, dear friends, yes, I should have got them from Pune. Mammography is the screening modality of choice for detection of breast cancer in the diagnostic setting to be used for all women after childbearing is complete. If possible, all women should avail the benefit of a 3D mammogram. USG is the modality of choice in young women and pregnant and lactating patients, but always keep a high level of suspicion. The MR imaging is to be used for a specific subset. Biorritz assessment criteria should be assigned and acted upon. Palpable breast lumps that do not fulfill all benign imaging criteria should be biopsied. Biopsy correlation is mandatory for all suspicious lesions. No additional imaging should obviate a biopsy. Thank you very much for a patient hearing. Thank you.